lecture series of clinical cardio class, the 3C of young cardiologists. Myself, Dr. Kamal Sharma, along with me, Dr. Marjan, Professor Head of the Department, KM Cardiology, and it's under the auspicious body of Indian Association of Clinical Medicine and the Gujarat chapter of Association of Physicians of Gujarat that we are covering this session, which is an important one. And today we have an expert faculty and an expert examiner from All India Institute of Medical Sciences, editor previous of Indian Heart Journal, a very good and a dynamic speaker, a leader, Dr. Rakesh Yadav sir. Professor Dr. Rakesh Yadav sir is a senior faculty at All India Institute, a very respected senior of mine and a good friend. And it's a pleasure to have him for this case presentation, second in the series, a case of dynamic LVOT obstruction. And as we were discussing at the back end before going on live on stage, that this is not usually, but almost always a case asked. Either very often it's a long case, but sometimes it usually is a short case, but sometimes it can be a long case as well. And for today, the case presenter is going to be Dr. Kirti from KEM, and she'll be presenting. But for the change, we have kept on demand of certain students that today we'll have the faculty talk first. Dr. Rakesh Yadav sir is first going to take us through his presentation where he'll be talking about evaluation of arrhythmic risk in a patient of LVOT obstruction. So which covers patients of sudden death, risk of arrhythmic sudden death included in a patient of HCM, apart from not just LV OT obstruction of HCM, but also from all types of LVOT. So with that, and without taking much of your time, I'll invite Dr. Professor Rakesh Yadav sir to take his talk first, and then we can have the case presentation by Dr. Kirti Kori, who will be presenting case of LVOT dynamic obstruction after the talk, where myself, Dr. Marjan, and Dr. Yadav, apart from me, Dr. Anil Kulshresht, Dr. Jitendra Anand, and Dr. BB Solanki also would be there to take the case presentation. So, Dr. Rakesh Yadav, sir, can we
Yes, sir.
stop sharing and we can have, yes, sir. Good evening.
I think
Over to you, sir.
service will.
Yes, sir.
Just my slides up. Oh, thank you, Kamal. I think it's a wonderful gathering. I always love to teach these students because they are the keen listeners. And the most important thing, what they want to listen is what is useful for them. If I am going to show you 100 studies and giving a 10 or 20 slides of this study, this material method, I think they all are bored because they just want a take-home message. And why it's important? Because if you have a case of dynamic LVOT obstruction, which we always say hypertrophic obstructive cardiomyopathy, this is an important part. I think the 20% of your viva will be on evaluation of risk for sudden cardiac death. Because this is very important. Severe AS will have a breathlessness, but there are less chances of sudden cardiac death as compared to dynamic LVOT obstruction. Now, we all believe that this hypertrophic cardiomyopathy is a monogenic heritable cardiomyopathy, and the prevalence is 1:200 to 500. It's not a very rare disease. Sarcomeric protein gene mutation was seen in about 30 to 60% of the cases, and marked genetic and phenotypic heterogeneity, largely under-recognized. So genetic heterogeneity make it more difficult to diagnose is in a family. Now, this is a natural course of history. It may be entirely benign, and I think more than 95% of hypertrophic cardiomyopathy, non-obstructive, goes a benign course, and people say that they have a normal longevity. However, a certain amount of hypertrophic cardiomyopathy, especially the obstructive variety, will have a sudden cardiac death, will have a progressive heart failure, which may lead to sometime non-obstructive will also lead to a dilated cardiomyopathy-like picture and progressive heart failure. And the most important thing, AF incidence is very high, and the chances of stroke are very high. So these are the 5 major prognosis profile of hypertrophic cardiomyopathy. Now, my topic is this: risk stratification for sudden cardiac death. It's very, very important. Why it is very important? Because we have seen a lot of news report, media reports, social media reports. A person is dying suddenly. It may not be only hypertrophic cardiomyopathy. It may be other variants, channelopathy, ARVC, but hypertrophic cardiomyopathy is one of the very important factors which lead to sudden cardiac death in some athlete also. Why there is a need for risk assessment? You can say that all hypertrophic cardiomyopathies are at a higher risk. I will say no. Why it's important? Beyond drug therapy, there's an important therapy which is known as implantable cardiac defibrillator. And this is shown to decrease the sudden cardiac death in majority of the population of dilated cardiomyopathy. Ischemic cardiomyopathy's ejection fraction is less than 35%, loss of channelopathy. So it is important, it prevents the sudden cardiac death. However, it's a costly therapy. There's a risk on inappropriate shock and device-related complications, lead-related complications, and putting it is not always 100% safe. So if there is a sudden death risk assessment is done, it's very crucial for these patients because the prevalence is very high. And it may lead to avoidance of unnecessary ICD therapy. So that is very, very important that you require to have a risk stratification, and you should prognosticate the patient. You belong to higher risk, you don't belong to higher risk. That will have a lot of prognostic significance for a patient. Now, going to the previous lot of studies, meta-analysis of these all small cohort, large cohort studies, which shows that if you see hypertrophic cardiomyopathy, all-cause mortality and sudden cardiac death is from 1 to 3%. So it's a quite high risk of sudden cardiac death. Now, what are the established risk factors? To start with 2014, this is very important. If you have a prior arrhythmic event, means aborted sudden cardiac death, documented VT, documented VF, the event rate is 10% per year. It's a very high event rate in these patients of hypertrophic cardiomyopathy. Now, this is a study, 730 patient study, followed for 4 years. 20% will have an appropriate intervention. IC discharge rate is 5% per year. And for a primary prevention, it is 4% per year. But if for a secondary prevention, it is 12% per year. It means if you are being given ICD for a secondary prevention, there is a 10% chance that ICD will fire a correct thing. Means you will have a VT-VF in next per year. It's a 10% per year. Now, when you have a family history sudden cardiac death, with or without family history, and this is an ample data here, particularly high risk if there are multiple SCD in your family. So if your 1 or 2 young child died because of sudden cardiac death and you are having hypertrophic cardiomyopathy, you have a very high chance of sudden cardiac death in future. And there will be malignant mutation may have a role in family history. Syncope, if you have an unexplained syncope, recent syncope less than 6 months, and if you are young, so these syncope, these patients have a higher risk of sudden cardiac death as compared to patients who are not having syncope. Now, massive LVH. Yes, this is all based on some previous studies. If you have a massive LVH, it is a strong and independent predictor of sudden cardiac death. Echo underestimate LV, so MRI is now being taken as a gold standard for thickness compare in patient with hypertrophic cardiomyopathy. And you go as your left ventricle wall thickness increases, the chances of sudden death increases from less than 0% to around 11 to 14% if your wall thickness is more than 30 millimeters. Now, presence of NSVT. The presence of NSVT is always a controversial subject in SCD. There's no evidence to suggest that frequency, duration, rate of NSVT influence risk of sudden cardiac death. However, in a younger patient, it has more significant. So an NSVT, if it's a younger patient, the study says that if you are having NSVT, you have a more chances. But NSVT as a clear evidence, clear assembly risk factor has not shown to be useful for predicting sudden cardiac death. Abnormal BP response. It has also been studies, and it has been suggested that failure to increase by at least 20 millimeter mercury, a drop of at least 20 millimeter mercury during effort may have a higher chance of sudden cardiac death. And it is the only manifestation of dynamic LVOT obstruction. It should be reassessed following invasive therapy to relieve outcome gradient. Risk modifiers. There's a lot of risk modifier like LG enhancement on MRI, LVOT gradient. If you have LV apical aneurysm, you are having young age, myocardial ischemia, LA diameter, and genotype. So this all has been attributed for assessing the high risk for sudden cardiac death in hypertrophic cardiomyopathy. The role of cardiac MRI. There's two thoughts, American and European. American thinks that the MRI has a crucial role in assessing the sudden cardiac death in hypertrophic cardiomyopathy when other risk factors are not indicated high risk. So in that risk stratification, MRI has a role. However, in a European society, still MRI is class 2B indication, not class 2, not class 1 indication. And we all see there's now, I think, a lot of studies done on MRI, LG enhancement in sudden cardiac death. And overall, if you have a LG of 40%, you have attributed risk is 3.45 as compared to when you have a 10%, which is 1.3. So that's why the role of MRI is there when you have a conventional risk stratification markers are not prominent and you have extensive LGE. I think 2A or 2B indication is various society to give ICD. So it can be utilized as an important potential factors for assessing the chance of sudden cardiac death in hypertrophic cardiomyopathy. LVOT gradient is again a controversial issue. However, the lot of studies favors that more LVOT gradient, more chance of sudden cardiac death. But it has a weak association with sudden cardiac death. Role of genetic in risk stratification, specific sarcomere mutation were initially attributed to sudden cardiac death. These malignant mutations usually limited to particular families. Currently, a specific genotype is not considered as a risk factor for sudden cardiac death in adult. It is very important. If you have a multiple risk factor, the chances of sudden cardiac increases. So you should always remember the number of risk factor which a patient is having, more risk factor, more chances of sudden cardiac death. And there's a linear relation. If you have a 1 risk factor, if you have 2 risk factor, if you have a 3 risk factor, the chances of sudden cardiac death increase drastically. Now, in 2011, this was an AHA recommendation. And they all include LA dilatation, abnormal exercise blood pressure response, family history of sudden cardiac death, history of cardiac arrest, unexplained syncope, severity of LVH, LVOT obstruction. So these all are being included in risk stratification, and accordingly, the class 1, class 2, class 3, class indication were formed. It was 2011. Now let us go what is a newer approach. Now, AHA recently has advised enhanced risk stratification model in which these 1, 2, 3, 4, 5, 6, 7 points are being taken. Family history of sudden cardiac death, LVH more than 30 millimeter, unexplained syncope, presence of NSVT, and stage phase means EF is less than 50%, LV apical aneurysm, and LGCMR. So that was an American risk stratification, and which truly in 2024 recent published guideline has advocated same thing. What they have now advocated? They have advocated major risk markers strategy advocated by the AHA, utilize a list of major risk markers to identify high risk patients. with one or more major risk markers, educating the patient to be at higher risk. So in American, these are all the risk markers. What are the risk markers? I will again enumerate. After the physician judgment of patient risk, emphasis is laid on shared decision making. They say you should discuss with the family and patient, considering the psychological aspect and the patient perspective on certain risk. LG and CMR related markers are included in this strategy, which might account for at least 20% of the appropriate ICD shock and hence a greater sensitivity. This strategy provides a sensitivity of about 95%, but a specificity of 78% with greater flexibility to both physician and the patients. And what are these major risk markers? Major risk marker included established 5-year SCD risk may be used, patient perspective address, LV systolic dysfunction, extensive LG, LV apical aneurysm, massive LVH, unexplained syncope, multiple repeated NSVT, family history of sudden cardiac death. So if any one of this is present, I think it is a physician judgment and he should discuss with a patient relative with a shared decision making for putting an ICD. However, European Society of Cardiology has a different score. They have SCM SCD risk score, and this risk score is you have to fill following things in a calculator, and these things is age, massive LV wall thickness, what is at present thickness, left atrial size, maximum LVOT gradient, family history of sudden cardiac death, non-sustained VT, unexplained syncope, and then you get a risk score at 5 years. So they say if your risk is less than 4, you belong to low risk. If your risk is more than 6, then you belong to high risk. High risk, definitely ICD is indicated. In low risk, no ICD is indicated. And in intermediate risk, I think this, you have to discuss with the family. When you discuss with the family, and then you can give ICD. But this is not designed for pediatrics. Pediatrics has a different score. Now, when you put this score, so there's a lot. This was initial recommendation by the European Society. Primary prevention and secondary prevention. So for secondary prevention, if life expectancy is more than 1 year, ICD is recommended. For a primary prevention, these are the history, 2D Doppler echogram, 48 hours ambulatory ECG, SCM risk, SCD variables, and you calculate the SCM risk. When less than 4, ICD generally not given. Intermediate risk, ICD may be considered. High risk, ICD should be considered. So that is a score. There's a lot of criticism of European risk calculator. Retrospective testing is an independent cohort of only 1,600 SCM patients. It is not a prospective study. Majority of the patient with or appropriate ICD intervention were misclassified with low risk. However, subsequent studies showed its useful role in identifying high-risk population effectively. So this is a difference between an American and a European. American believe on major risk marker, European believe on risk scores, which should be calculated. It is absolutely a objective thing. ICD decision based on more than one major risk, more than SCM risk score. Shared decision making is recommended in American, but it is only recommended in low risk patients. Sensitivity in American is very high, but specificity of European is very high, is 92%. And these are all the markers. LG on CMRI not included as a variable in the risk score, but European Society of Cardiology 2023 guideline recommend use in a low risk patient class 2B indication. And age in American not included as a major risk marker, but given weighted as a variable that might impact decision making. So this is the, I always say, the algorithm which we all follow. When you have a history of sudden cardiac death, VF, sustained VT is a class 1 recommendation. When you don't have these all, at least one of the following: family history of sudden cardiac death, massive LPH more than 30 millimeter, unexplained syncope, apical aneurysm, EF less than 50%, yes, ICD is reasonable. When you don't have these all, no, then NSVT, yes, if you have an NSVT in children, ICD is reasonable, but in adult, ICD's class 2B indication. If there's no NSVT in low risk patient, if a patient again wants that my risk assessment should be complete, then I think MRI LG enhancement is more than 15%, you may consider it. But if there is no extensive LG on MRI, ICD is not indicated, is harms. So these algorithm we are following at present here. So these are the established risk factors, potential risk factor, and this should be considered when you are going to give the risk assessment for sudden cardiac death in hypertrophic cardiomyopathy. You believe in American, you believe in European. I think whatever you believe, the assessment of risk should be stratified in all patients of hypertrophic cardiomyopathy, especially obstructive hypertrophic cardiomyopathy. So always do whatever you are believing, you believe that, but give a risk factor that this patient belong to high risk, this patient belong to low risk, because over and above medications, the ICD therapy is very important for preventing this sudden cardiac death in these patients. For pediatrics, it is now being increasingly recognized that pediatric SCM behaves differently than adult SCM. With a preponderance of syndromic and metabolic cause in infancy, a lower prevalence of SCM compared to adult, a higher sudden cardiac risk, and different weightage of risk factor for sudden cardiac death. Adult models applied to pediatrics SCM have been found to underestimate the risk with limited discriminatory power. Added to this is a higher risk of device-related complication in adult, which necessitate separate risk stratification tool for pediatric hypertrophic cardiomyopathy. Among the various risk factors for sudden death, a family history of sudden death is not predictive of risk in the pediatric population, and therefore is excluded from most pediatric risk score. LVOT gradient has been either found not to be associated or inversely associated with sudden death risk in some studies, making it as a less useful variable in a pediatric population. Genotype status is predictive of sudden cardiac death in the pediatric population and therefore has been included in some pediatric risk score. That is SCM risk kits score. This score is not validated for patient less than 1 year and more than 16 of age, patient with a secondary prevention ICD indication, syndromic SCM, and SCM associated with inborn error of metabolism. So these are the pediatric risk score, adult risk score, and pediatric risk score, which include from 1 to 16 years. Yes, massive LV wall thickness, left atrial diameter is being included, LVOT gradient is being excluded, NSVT, history of NSVT in prior 6 months, unexplained syncope in prior 6 months, weightage was given to height, genotypic status, but family history is not included in this. Some has included LVOT gradient as a marker, but LVOT gradient has a lower value when you are predicting the risk score in pediatric population. So if you have a family history of sudden cardiac death, and your child is young, I think don't try to give ICD in these patients because the predictive value for sudden cardiac death is not very good. So these are the difference between adult and pediatrics. So for adult, you have a very good emphasis on family history of sudden cardiac death, but pediatrics, it is not. LVOT gradient, though included, it has a less predictive value for sudden cardiac death. However, certain studies shows that genotypic status in a pediatric population has more weightage as compared to the adult, in which we don't take genetic study for predicting risk stratification. So that is very, very important. When you have a hypertrophic obstructive cardiomyopathy patient comes, you have to evaluate in 2 aspects. What is the risk of sudden cardiac death and what's the risk of advanced heart failure? Because a lot of therapy will depend upon the symptom of the patient's of breathlessness and chances of sudden cardiac death. So you have to balance both. If a patient is mildly symptomatic, I think beta blocker is an obstructive cardiomyopathy. The gradient is 20. Patient is mildly symptomatic, no family history, sudden cardiac death, no NSVT, no syncope. Your LVH is not very high. It is about 24 millimeter then. So what you will do? These patients require therapy, no therapy, because they are mildly symptomatic. Don't try to give a lot of beta blocker, calcium channel blocker, diuretics in these patients because diuretic harm these patients. And don't unnecessarily advise ICD therapy. So you have to balance. That is a very, very important in when you are treating hypertrophic cardiomyopathy. Always remember the advanced therapy in hypertrophic obstructive cardiomyopathy, like when you are telling them for a septal ablation or myomectomy, entirely depend upon symptoms. Till patient is class 2 symptomatic, don't take these patients for septal ablation or surgery. That is a very clear in all guidelines. That is very, very important. Second important thing, I will just compare one or two, this one slide. Prevention of sudden cardiac death is very important. Patient may be entirely asymptomatic. However, in a European or American risk stratifier category, they belong to high risk. You have to give them ICD. Patient may be class 2 symptomatic, but doesn't belong to list of prevention of sudden cardiac death markers. Don't give ICD, give drugs. Try to give beyond drugs, septal direction therapy. So that is very, very important. And second important thing in when you are treating the patient of hypertrophic cardiomyopathy, if a patient is symptomatically angina, always try to do angiography. If a patient has AF, treat AF. In AF, we always believe rhythm strategy is more important in HOCM than rate control study. So as far as you can have a rhythm maintenance strategy, that is more useful for these patients of hypertrophic obstructive cardiomyopathy. As they develop AF, symptomatically they deteriorate. Third important thing, don't give a lot of diuretics when patient present with heart failure symptom. Patient is class 2, class 3 breathlessness, don't give diuretics. Because when you give diuretics, the LVOT gradient will increase. So that is very, very important thing in patients of symptomatically. And this is a general measure. Maintain proper hydration, avoid excessive alcohol, stimulant, extreme of temperature, intense exercise, high dose of vasodilator. Don't give sildenafil, nitrates, inhibitor in these patients. So these all has to be taken care when you are treating these patients. So to conclude my talk, the risk stratification for sudden cardiac death is very, very important when you have a patient of hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy, because the therapy, which is a costly therapy, depends upon various scores. So this is how you risk stratify, and risk stratification is always important when you're planning a treatment for hypertrophic obstructive cardiomyopathy. Thank you very much for your kind attention.
Thank you very much. A wonderful talk, as expected, covering not only indications but the controversies around AICD. You also covered how the Americans and Europeans differ in these evidence synthesis, especially. I think a lot of it, especially the controversy that arises around LGE on cardiac MR. You also touched upon important aspect of medical care, though I expected you to cover that as well, which you very beautifully covered the common mistakes that are done, avoiding, I mean, pushing a diuretic, which is a big problem. Dyspnea in these patients is not related to volume. Actually, they are volume deprived. You also covered about drugs that cannot be given, how pediatric guidelines differ from adults. And that's a beautiful nutshell summary of what to do and what not to do. So wonderful, sir, talk. Thank you very much. We can begin, and also very much you have been on time, sir. Perfectly finishing, starting on time and finishing on time. That's how it's been, sir.
Thank you.
So I think we can start with Dr.
Karthikesh.
Kirti Kori's presentation now. Uh,
Yes.
yeah, so we have Dr. Anil also with us. Dr. Anil Gulshresh, Dr. Rakesh Yadav, myself, and Dr. Marjan will be joining soon. And Dr. Kirti, you can start with your presentation.
Good evening, everyone. I'm Dr. Kirti. I'll be presenting this case. Shall I share my screen?
Yes, please. So Dr. Kirti is a resident in cardiology at KEM Hospital, Mumbai. Kirti, your third year or second year?
So third year.
Third year. Great. Okay, you can start.
Um, Good evening, everyone. I'll be presenting a case of 49-year-old male patient, graduate, a resident of Buldana district, and is teacher by occupation, presented with complaints of exertion breathlessness since 2 years, exertional chest discomfort since 1 year, palpitation and associated presyncope 1 month back. History of present illness, patient experienced breathlessness on exertion, which is insidious in onset, uh, gradually progressive in nature. Started 2 years back when he quickly climbed 3 flight of stairs, which settled after 10 to 15 minutes of rest. He restricted his activities and felt better. He remained asymptomatic with restricted activities and experienced dyspnea on exertion only when he used to walk 1 kilometer when he go to till the marketplace, or he used to climb 1 flight of stair. Suggestive of NYHA function class 2. The breathless was associated with diaphoresis. There is no diurnal variation. He consulted a local practitioner who advised him to consult a cardiologist and told him that he needs further investigation. There's no history of PND or orthopnea, no complaint of cough with expectoration or seasonal variation or wheeze, no history of pedal edema, abdominal pain, or decreased appetite. He started experiencing exertional chest discomfort of variable threshold when he used to climb stairs since last past 1 year. It is left-sided constricting pain, non-radiating, more after taking heavy meals and with exertion. It is relieved by rest associated with sweating. He used to stop exertion when he feels chest discomfort, and then he feels relieved. There's no diurnal
Okay,
variation.
so Kirti, why this pain after meals? I mean, a lot of people tend to stress upon this in patients' history with HCM. Do you think this is specific for hypertrophic cardiomyopathy, or it's an association?
It is just it is significant for all cardiac pain since there is an increase in
Yes.
the
So it's not, I mean,
demand.
though the description of angina in a patient of HCM from a CAD has been often taught as that maybe the patient, if he experiences angina after meals, it is more likely to be HCM. It's not the case, right? Why do they experience angina more after meals?
More after heavy meals because there is an increase in demand. There is increase in the splanchnic blood circulation, and there is an increase in demand, and there is a demand supply mismatch because of that.
No, in CAD or in HCM?
Uh, in
Is in
in both of them.
CAD? No. So in HCM, the mechanism is same. Is a demand supply mismatch?
Uh,
So
in
what
SCD,
happens to the splanchnic bed when there is meal? This splanchnic vasodilation.
vasodilation is
Vasodilation is the mechanism
decrease in
in
the
HCM.
SVR. Okay, the
Yeah, so the
decrease in the SVR.
mechanisms are different.
Yes,
That's
yes,
what you should. So the
yes,
causes, though they say that postprandial angina in HCM is more often seen and described, but it's primarily to distinguish the mechanisms and understanding of pathophysiology. It's a splanchnic vasodilatation, fall in SVR, which leads to. So it's not a demand
easily.
supply mismatch as you have, right, in the CAD, where it is dilatation, of course, but it's more of distributive ischemia. Here it's the SVR fall rather than the distributive ischemia.
Yes.
What about dyspnea? You said 3 flights of stairs. Do you think it's usual, unusual for somebody to get dyspneic on climbing 3 flights of stairs?
Since it is unusual because since he lives on the third floor, so he used to it's on the daily practice that he used to climb 3 stairs. But
Right.
since 2 years,
So functional class, when you talk about, when you described, you said functional class 2. Usually it is expected from you to categorize it by one or the other classification rather than just keep it functional class. Because whether you're using American Heart Association, Canadian Cardiac Society, WHO, or you're using nothing but NYHA. So what classification you've used is functional class means it can be anything. It can be visual analog scale for angina. So it's better to quantify and describe. So you said functional class, that's
and,
fine,
and
but which classification you used is also important. I think
and
you use functional class, right? NYHA you didn't mention. Go back to your slide if you can. You can see it's written FC. Okay, you've written
and
NYHA. I overlooked. Okay, fine. So NYHA, you need to describe which classification you're using. Is
sure.
it important? Why do you tend to use NYHA more for dyspnea?
and CCS for angina. Usually they say Canadian Cardiac Society for angina, NYHA for dyspnea, though you can use NYHA for angina as well. But why is angina more classically described with CCS rather than NYHA?
Sir, Canadian Society of Classification for Angina is it's particularly meant for angina, and then they have a different
No, but even see, NYHA is used for
for dyspnea, fatigue, angina, and palpitation.
correct. So why don't you use that? Why is CCS preferred? You can use NYHA for angina as well, but it's advice. I mean, CCS is more likely to be more accurate. Why? So see, you can be asked the classical questions, describe NYHA class one. You can be so the examiner can ask you the same question, whether you understand the concept or not, in a twisted fashion. He can frame around the question differently. What I'm asking you actually is nothing but how is CCS different from NYHA? If you look at CCS, it describes activities. This is more specific day-to-day activities, and hence it's more likely to be accurate in terms of severity, also in terms of monitoring. By NYHA, as you know, class, it says routine more than routine, ordinary less than
Ordinary.
ordinary, right?
Yes.
So then that's ordinary less than ordinary would differ between two individuals, and also for the same individual at two different time frames, when he was say 10 years younger and now he's 10 years old. I mean, older than what he was previously. So somebody who was 30 years of age was able to take 3 flights of stairs, may not be able to take when he turns 50, and he may not actually have worsening of disease. And that's why you want the activity to be utilized rather than the ordinary being described as the one. So climbing 2 flights and 3 flights would be more quantifiable in CCS than in NYHA.
Yes.
Okay, you said there is no PND. Why do patients of HCM don't have PND? Or is it uncommon, or do they can have
It's
PND?
uncommon.
Why is
HCM
it
patients,
uncommon?
because decrease in the respiratory, decrease in the heart rate, which increases diastolic filling pressure and increases the
So one
coronary
is fall,
perfusion.
yeah. So one is reduction in the heart rate. Second,
Um,
what
then
about the volume return, supine position?
yeah, there is increase in the volume
Venous
return, so
return
increasing the
also. So volume. So
preload and
anything,
decreasing the
basically, whenever you are asked about anything in HCM or MVP, just look at three aspects. What are those three aspects? Force of
preload,
contraction,
afterload, and
preload, and
contraction.
afterload.
Yes.
Anything that increases force of contraction, anything which reduces preload or decreases afterload is going to make the LV cavity smaller. With the contractions going up, is going to make the symptoms worse. So if a patient who's got has gone to sleep, his heart rate is going to go down, his venous return is going to improve, his systemic vascular resistance though falls. So I could have asked you a question in a different fashion. Though in sleep, systemic vascular resistance decreases because of relaxation, still the patient does not get PND. Why? So the answer is reduction in force of contraction and increased venous return. Okay,
Yes.
so that is nullifying and taking care of it. What about sudden death in sleep in patients with HCM? Is it common or uncommon compared to other sudden death etiologies? I think a lot of it, Dr. Professor Rakesh Yadav sir covered. Sudden deaths in HCM, activity versus sleep. Which disorders you get more sudden deaths in sleep?
Um, Sir, LQT syndromes or
All
Which
all
character.
LQTs?
LQTs, all
Which
LQTs.
LQT?
No, sir, LQT 3.
Yes.
Sure. So one, two, three. Who gets on activity, who gets on sleep, who gets in swimming, who gets on loud sound. So that's where so when you're given a case of HCM, be prepared that your viva can go on sudden death. Okay. And that's where all your arrhythmia, sudden death evaluation also can come in. Don't be thinking that dynamic auscultation will get you around. So correct. So one is long QT syndrome, sudden death in sleep. Then
Um, Sir,
dilated
dilated
cardiomyopathies.
cardiomyopathy.
Yes, compared to hypertrophic cardiomyopathy. Hypertrophic cardiomyopathies are classically activity related.
Activity related.
Activity related. Usually, but you can get it at any point of time. There are no data as such sets between the two, but That's what where you will look into. So again, why they don't get in sleep is again because of the similar reasons that they don't get PND. Arrhythmia risk also because sympathetic activity goes
Is
down,
decreased.
arrhythmia risk goes down, atrial kick is improved, filling is better, LA is smaller, everything is that way more suitable, theoretically speaking, that these patients don't get PND in orthopnea unless they have. So then the next question can be, tell me causes of PND in a patient of previously a patient of HCM now comes with PND. What are your suspicions?
Patient might have developed LV systolic dysfunction,
Yes, so burnout, as you call it,
burnout,
burnout
HCM.
burnout HCM, which gets into DCMP, can present. Then,
Patient might have developed AFib, paroxysmal episode of
very
AFib.
good, very good. Arrhythmias. Then, can they have associated coronary artery disease?
Associated coronary disease. Yes, sir.
So, how often do you find coronary artery disease in patients with HCM or in patients with, say, rheumatic aortic stenosis?
HCM patient mostly present with NSTEMI, if at all they present with the
Is it truly NSTEMI or they present with something else? What is that new terminology called as?
myocardial bridge or
No, it's called as MINOCA. What is
Minuca.
MINOCA?
Myocardial infarction and non-obstructive coronary disease.
Correct. So most of the patients of HCM present with MINOCA
Minuca.
rather than NSTM. I mean, of course, troponins are elevated, but they usually present with MINOCA.
Yes.
And what as I was asking, how often do you find CAD in these patients? Any series you know? Rheumatic series you know? Autopsy series is autopsies done in valvular heart disease of rheumatic etiology in India showing X percentage with CAD. Any series?
One of is there Kumar et al.
No, I'm asking you because you're from the institute from where this was published.
It's a K.
KM. So which series?
So there was one K
The
process.
most famous person who used to do most of the autopsy series in cardiology come from KEM from one
Prafulla
pathologist.
sir, is that,
Sorry?
Dr. Prafulla sir from pathology.
No.
Dr. Sen and Kinare,
Yes,
Suman Kinare.
Dr. Kinare.
Suman Kinare.
So
Yes.
yeah. So you should know. I mean, see, your institute, if I'm external, I'll be more interested in knowing whether you know your institute's paper. That's the other trick in exam. So if I'm going to AIMS, I'll be keen in asking what did SB Roy did, what was SB Agrawal's contribution, what is juvenile mitral stenosis, and then I can always count, ye tumhare institute ka hai, tumko nahi pata, that types. You know, this is a usual tendency of an examiner to ask you whether you're aware of things that are coming from your own institute. So I can go and ask you, do you know Kinare's series? What are the other autopsy series that you know? And again, if you go through Kinare's autopsy series, they will tell you even at HCM, though the number of patients were less, the incidence was in the range of 10 to 15% in valvular heart disease, non-valvular because the numbers were small. I mean, LVOT obstruction, the numbers were not quantifiable in terms as he mentioned in his publication. Majan sir, any other question?
No question from my side.
Yadav sir? Okay, you can go ahead. Kirti, next slide.
He had an episode of palpitation 1 month back in form of sudden, rapid, regular, forceful pounding sensation in chest when he went to the market, which is associated with pre-syncope. He quickly recovered and his palpitation also settled. It is not associated with any involuntary movement, urination, defecation, or tongue bite. He consulted a cardiologist who told him that he has a heart disease and needs evaluation. He also was given two oral tablets, one of which was oral beta blocker, which gave him partial relief.
Okay, now again, because you were mentioning about sudden death, and I was discussing that to complete that question, it was left incomplete. Which are the other arrhythmic disorders that get precipitated on activity? Long QT we covered HCM. Now that opens up your Brunwald's chapter, that page which covers all the syndromic sudden deaths. Can you tell me some of them?
With exercise, catecholaminergic ventricular VT.
CPVT, correct, very
CPVT.
good. CPVT, so catecholamergic polymorphic VTs. it's again common. What about Brugada? Is it exertional or not exertional?
Oh, so it is exertional.
So how do you bring out the Brugada sign? Is it by activity or
Fleckner test, matlab,
so
with the
once
test.
it need not be exertional? Again, any other syndromic deaths that you know? What is Anderson-Tawil?
Anderson-Tawil syndrome, short QT syndrome.
So even short QTs can be
Short QT.
responsible, right? Even
Yes.
they are. What about early repolarization syndrome? Are ERS arrhythmic or they are benign?
Sir,
So
earlier it
somebody
was
comes
thought,
in and you do an ECG, 20-year-old boy, you look at an ECG, looks like early repolarization. You reassure him you don't have an MI. But what do you say now about his
now
risk? He asks you.
ERS is also, it is not that benign. It is also, it has a
Absolutely.
arrhythmogenic substrate.
Right. So which cells are these which are responsible for ERS? Where do that spike come from? How do you differentiate ERS, early repolarization, from a physiological or acute MI-tall T?
J point elevation in ERS.
Okay, what is that hump called as? So see, Viva, you are prepared for HCM, but your Viva can go on sudden, as Dr. Yadav was saying, sudden death constitutes 20% of your Viva. A lot of times it'll be arrhythmia. Once you say no history of sudden death, very likely you'll be tracked around that thing. Okay, how do you differentiate pre-syncope of cardiac etiology or syncope of cardiac etiology from neurologic etiology? Again, that's the other EGASIS criteria. Again, you should know about
Yes.
other criteria. What are
Yes.
the important criteria to differentiate between the two? So
Yeah.
the Viva can go right from your history to sudden death, to syncope, to convulsions, to angina, types of angina, PND, dyspnea, burnout, autopsies, hypertension. I'm just giving you certain traits and directions where the Viva can go. Okay, go ahead.
Past history, he is a known case of
If there is
hypertension.
no positive history, you can skip for the sake of time so that we can have more
There's
Viva.
no significant family history as well.
Okay,
Three generation pedigree is not significant.
right.
Differential diagnosis.
So can you summarize quickly your and
My
then
patient is
we'll come to
a
yeah.
49-year male patient who's presented with exertional breathlessness, exertional chest discomfort, and one episode of palpitation associated with pre-syncope 1 month back.
Okay. So now let's go to your differentials.
First differential is coronary artery disease, valvular heart disease,
So what is his age?
49 years.
Right. So do you expect this to, will you call it young CAD?
No, sir. Less than 40
No,
years.
less than 40. So again, remember then whenever you give certain differentials, you should be prepared that what data you're talking about. When you're talking about 49, he would by two definitions. So one definition is the Caucasian definition, and there are papers in Indian Heart Journal and even including our own series where the definition of young, very young. Yes, sir. Dr. Yadav?
Hello.
Sir. Right. So young CAD, as we were saying, less than 55 is the classical definition, right? But there are also people who have been defining it less than 45 for Indians because Indians tend to get it a decade earlier from the INAS series compared to Caucasians. Again, very young is defined as less than 30. Again, a paper published in Indian Heart itself. So young, very young definition. So again, why would you put a CAD ahead of LVOT obstruction in this case?
Uh, sorry.
So
Is it?
dyspnea preceding angina, right?
Yes, sir.
Right. So that's slightly disproportionate. You don't have CAD, but then if I ask you that, then you should be able to justify. You can say angina,
Angina.
dyspnea. It can be as an angina equivalent, right? It can masquerade, or
Yes.
patients can have silent ischemia with developing LV dysfunction, and patient can develop angina later on, right? Then
Yes.
you can have associated disorders. So CAD, of course, remains the commonest etiology in a 50-year-old patient, but though he does not have any other risk factor. What are the traditional? So when you put CAD, be prepared. Young CAD, CAD risk factor, inter-heart score. How do you assess it? What are the 10 classical risk factor? What are the cutoffs of various values? Lipolitile ka kya role hai? What is about homocysteine? What level of evidence does it give for the assessment? Those are some of the questions that you should be prepared. You can join in for the young CAD session that we already have, young case later on. I'm not spending time. Let's stick to obstructive cardiomyopathy that we are looking at. So second you put is aortic stenosis. Which kind of aortic stenosis are you looking at here? Valvular in which form?
uh,
49
valvular, acquired valvular,
Yeah, so rheumatic,
rheumatic,
rheumatic or bicuspid or sclerodegenerative or Leves disease or Lenegres disease or Schneer's. You know the causes, right? Aortic
yes,
stenosis. There is a long list. So
yes.
what are you looking at?
Acquired non-rheumatic, sir.
Non-rheumatic. So usually stick to your common things first. Talk about maybe bicuspid.
Maybe.
Maybe bicuspid, right? 49, you don't expect sclerodegenerative early 50s, 60s. You don't expect rheumatic coming so late if it's early, isolated without, or it's not just aortic stenosis. You're thinking probably of a multivalvular heart disease. Dyspnea is preceding. It may be MS with AS or MS with AR or MS with MR or angina, so aortic valve, of course, and then mitral would explain dyspnea. So you don't have to stick to saying AS without clinical examination. Right. And then you mentioned hypertrophic cardiomyopathy. Dr. Majan, sir, any questions?
No question from my side.
Okay. Go ahead. Kirti, your differentials are
Example,
done. Let's go to exam. Yeah.
patient is comfortable, cooperative, no pallor, icterus, sinus or clubbing. Height 165, weight 63 with BMI of 23, arm span of 158, and no significant difference in upper segment of 89 and lower segment of 76. Pulse rate is 78 per minute, regular with normal volume, rapid rising, difference in character with normal condition of arterial wall. Bilateral carotid artery, carotid is equally palpable. All peripheral pulses are well equally felt equally with no radial or radiofemoral delay. BP of 140 by 80 in right upper limb, 142 and 84 in left upper limb, and in supine position, 144 by 76 in right lower limb, and 148 by 82 in left lower limb. Jugular venous pressure is mean pressure is not raised with prominent A wave. JVP is 3 centimeter above the sternal angle in 45-degree head up position. Other waves and descents are normal with normal respiratory variation. Abdominal jugular reflux is normal. SpO2 is 98 in both upper limb and lower limb. There's no features of infective endocarditis, marfanoid habitus, or dysmorphic faces.
Right.
Cardiovascular examination.
So come back to general exam. What are the things that you're ruling out from this?
Sir,
So
I have
you
ruled out
again the
aortic
framing. Yeah. Sorry. Please go ahead.
sir, I have ruled out stenotic lesion like aortic stenosis.
How? From just the general exam, you ruled out aortic stenosis. How?
Sir, it is a normal volume pulse.
Okay. Okay, so let me put it now. Go back to your differential. So whenever see the examiner is interested in your approach, I want to know. Yeah. So your differentials was what was your first differential?
Coronary artery disease. I've
Yes.
ruled out.
How did you rule it out in general exam? So then look at
Presence of
the
difference character of pulse.
no go forward. So you don't have peripheral stigmata of CAD. What are they? Xanthomas,
Xanthomas,
xanthelasma,
methalasmas,
yes,
this auricle sign,
arcus,
arcus sign,
yes, and the Frank sign,
Frank sign.
right, premature balding, etc., etc. So there is a long list. So whenever you are asked what did you rule out or what did you confirm, always remember what you've spoken. You've spoken a differential where you have put something as first. That's what you're thinking and ruling out. Again, second thing that you mentioned that since the white pulse pressure is still not so narrow, it rules out a valvular stenotic lesion. Okay, aortic lesion. So
Okay.
it's 140/80 probably, and the pulse character, as you mentioned, bisvariance in character. But does that mean that you've completely ruled out?
No, sir.
No, it can
It
still
can be
be
more.
AS with AR.
Yes, sir.
It can still be AS with AR. Okay. Now bisvariance, when you talk about HCM versus ASAR,
Uh,
how are the two bisvariants? Are they similar or are they different?
so they are different. In HCM, there's a normal volume difference, but with severe AR and moderate AS, the volume is increased.
So they call it the two things
Two
here. One difference is the character of bisvariance in HCM is called a spike
spike.
and dome pattern. Secondly, it's more recordable than palpable. If you're getting a bisvariance palpable, either it's a very bad LVOTO in a patient with an HCM with ongoing LVOTO obstruction when you're auscultating in a phase where you have induced the obstruction. So, which would be not a supine position naturally, it would be on standing or something like that, right? Secondly, the of course, so it's usually HCM patients don't have bisvariance. Okay, bisvariance doesn't classically get palpable bisvariance as they call in a average HCM patient. It's only in severe HCM, usually recordable, but when palpable, it's a spike and dome pattern. So spike and dome. So you may be asked, Kirti, to draw a bisvariance of HCM versus bisvariance of ASAR. So you should know the arterial waveform. And then once that is opened up, the other examiner may be interested. Okay, now draw alternans, now draw dicrotic, now draw anacrotic, now draw bifid. So they can ask you anything. So
Yes, sir.
just be prepared. This is one exam where the pulse character to be drawn is something that you should be knowing. They'll ask you to draw in your answer sheet and take that answer sheet to the university and create, see, this is what they drew, this is incorrect, something like that. So make sure that you know how to draw these pulses.
Yes, sir.
Where is, so okay, I'll not go which pulse is palpated where and all that. Bisvariance, of course, they say is, Harrison mentions is best palpated in carotids, though they
But
say
it
it's,
can.
yeah, it can be equally good in brachial as well. So,
Yes, sir.
but both of them is fair and right. Brachial is also good to palpate, and carotids, of course, bisvariance is good to go. You mentioned pulse pressure, that also JVP would tell you that probably. So, why would JVP tell you that it's, what does a prominent A tell you?
Since there is the hypertrophied LVH causes the interventricular bulge, which causes due to Burnham effect, there is a prominent AV.
So Bernheim effect, that's correct. So Bernheim effect can cause a prominent A in a patient with HCM. Very good. What is reverse Bernheim?
In case of RVH, there is
So pulmonary arterial
current
hypertension, there will be reverse bulging of
reverse
the
burning.
septum towards the LV, which
LV.
can lead to impaired LV filling, and you can have a false diagnosis of LV diastolic dysfunction when
Dysfunction.
actually patient may not have primarily LV diastolic. It's primarily because of the RVP pressures that is coming in. Okay, so those are the things. Go ahead to the other exam. Dr. Anilvi, you want to ask something? Okay, go ahead.
Cardiovascular examination, inspection, and palpation done together. Chest is symmetrical with transverse diameter more than anterior posterior diameter with no bulge. Apex impulse is seen and felt on fifth intercostal space, 1 centimeter outside midclavicular line. Trachea is in center. Double apex impulse is palpable with both impulses in systole. It is sustained, forceful LV type apex. More
So,
prominent in
what do you
left.
call it? Double impulse. What is classically described in HCM?
Triple ripple is
Correct.
classically
So, ideally, you would expect. Now, remember, again, when you're mentioning an A wave on JVP, means the LA is kicking hard,
hypertrophic LV.
right?
Yes.
Right. So you would expect an LA kick as well.
Yes.
But because sometimes you may have just the Bernheim, the LA may not be kicking so hard. Septal hypertrophy, bulge to the right, high LV and diastolic, means getting an A wave in JVP means LA has to work hard. So usually all will go together. You cannot say S4 absent, which you mentioned, of course, S4 is palpable. S4, A wave, and also the triple ripple would go in sync. It's just like that. If you're hearing, it cannot be like in mitral stenosis. You cannot have S1 is soft but opening snap is audible. Never happens, right? Both of them are done through the same mechanism.
Yes.
Same way, these three things. Same I also say for pulmonary arterial hypertension. You cannot say P2 is not audible or P2 is normal, but diastolic shock is present, or parasternal heave is present, but P2 is not audible, or diastolic shock is not palpable, but parasternal heave is present, unless that heave is of LA, right? So, of course, not relevant to this case, but these are the common mistakes these students make. We don't want you to contradict yourself. We may contradict you is a different story, but your findings should not contradict your own findings. At least those should be in sync. So good that you mentioned it. Triple ripple may or may not be palpable. Double apex is fairly enough. Why does it happen? I think you mentioned it, that it would be the obstruction that is overcome by the forceful contraction.
Also context
When
of
would
that.
it disappear?
With LV systolic dysfunction,
Very good. Or
uh, with AFib.
AFib, why should it disappear with AFib? Something else in the left ventricle that it's not getting bifid.
Clot in the LV.
No, so aneurysm,
Aneurysm.
not a clot, LV
Clot.
aneurysm. But what do you get in LV aneurysm is the paradoxical apex,
Apex, yes.
right? What
Yes.
about bundle branch block,
Uh,
LBBB?
LBB.
What will happen with LBBB?
With
The force
LBB,
will of course go down. So people
go
say with
down.
LBBB also it can be.
Force. Yes.
Yeah, it may not be the double apex that you get.
Yes.
All right. Okay, go ahead.
A systolic thrill also felt in the left intercostal space, close to the sternum, better felt with the patient standing. Palpable S4 just before the systole at apex. In percussion, liver dullness is present in the right fifth intercostal space in mid-clavicular line. Left heart border corresponds to apex. Right heart border is substernal. No abnormal percussion finding. Auscultation S1 is normal. S2 is normal in intensity with narrow split. No S3. S4 is audible at apex in left lateral position with bell of stethoscope. No click or opening snap. There is harsh crescendo discrescendo ejection systolic murmur. Best audible, high pitched with best audible at lower left sternal border with a diaphragm of stethoscope. Increase on standing and strain phase of Valsalva. Decrease on squatting on a hand grip. Not conducted to carotids. Grade 4/6. There's another late systolic murmur, which is blowing in character, high pitched at apex, conducted to axilla, better audible on standing, and decrease on hand grip and squatting. Grade 3/6. There's no other murmur and no features of heart failure.
Right. So now you've done well. You've done spoken about the dynamic auscultation. A couple of things that you've done. Let me go through the common questions everybody is able to get through. So I'll cover those questions in this session which are not given anywhere. Some of the questions that I usually ask, which are credit questions, you're doing well. So how does effect of amyl nitrate differ from sublingual nitrate?
Since sublingual nitrate or any uh, in spray sublingual or a nitrate spray,
Is it same?
it is only a venodilator, and amyl
Right.
nitrate is a arterial dilator as well,
Only
which
arterial?
causes arterial plus venodilator both,
It's both, right?
which
So what will
causes
be the
decrease
effect
in the
on this
afterload and
murmur?
reflex tachycardia.
Right. So what will be effect here?
Increase in
This
the
patient.
obstruction. Since there
With
is a
which one?
uh, with the nitrate, there is increase in obstruction, sublingual nitrate,
So you
and
mean the murmur will worsen?
worsen. Yes, sir.
Okay. When? Immediately?
With sublingual nitrate, immediately.
What about amyl nitrate?
Injectable amyl nitrate,
No, no, not injectable. Amyl nitrate is a bulb that's. So is amyl nitrate available? And how is it to be
not
given?
available in India.
Not available. How is it given? It's an
Uh,
ampule to be
Ampule
broken and to be
broken and
inhaled. That's
inhaled.
how it is done. What can you use now that amyl nitrate is not available and you are still a thorough clinician? You want to do something. What can you use which is available? Which you use in your
Isotretinoin,
pediatric patients very often, I assume. You have that in KEM's pediatric units. You have a nitric oxide?
nitric oxide. Not in ICU, matlab cardiac ICU.
Pediatric ICU. Just cross check if your pediatric
Yeah.
ICU has nitric oxide for neonatal hypoxic patients who are born. For them, that's where usually most of the departments get it first. So nitric oxide, I don't know. I mean, that's how it came in our institute, and then of course it's there with the adult ICU as well. I mean, in the CTOT side. So nitric oxide, it's not. So that's what you can use, but again, it's very costly. Nobody will let you do it for clinical exam. The problem with what will happen with amyl nitrate? First
It
few
will increase
beats,
after
second beat, third beat, fifth beat, 10th beat, 20 beats.
beat
That's what you
variation.
should know. First, the venodilator, then the arterial. Immediate reflux, fall in SVR, decrease in the venous return. Subsequent cycles, the venous returns come back. And the increased venous return, fifth, sixth cycle, you have more cardiac output, more blood reaching on the left side. Immediate effect is arteriodilator, right? So first there is fall in SVR, So that's how so amyl nitrate, as you correctly mentioned, amyl nitrate is both systemic veno and arterial dilator. Sublingual nitrate or nitroglycerin spinel is only venodilator. How does murmur of MVPMR and HOCMMR change by dynamic auscultation? Both move in the same direction or no?
Withstanding the HCM murmur, the length increases, and MVP, the loudness increases with sanding. And
Very
hand grip,
good. Very good.
hand grip decreases the MVP
So
murmur and
length
increases
versus intensity is the key
intensity.
word. One is the length, the other is the intensity. Correct. Can you tell me a murmur that disappears with amyl nitrate?
Disappears.
Murmur of MR. So
MR.
how do you differentiate murmur of MVP MR, DCMP MR, rheumatic MR? Three MRs, three can be differentiated by amyl nitrate.
Okay. With the amyl nitrate, MVP MR disappears, I guess.
Why should it disappear? You just mentioned what happens to that murmur.
It
What
should
happens
be
to that murmur?
DCMPMR.
DCMP MR
Yes, DCMP disappears, no?
disappears.
Venodilator, arterial
Mhm.
dilator fall and so everything forward output. DCMP-MR disappears. DCMP-MR can disappear. But rheumatic versus MVP, what happens to the LV cavity, MVP?
When the cavity increases,
What
and,
happens to, again, go back, you already answered it. HCM, MR, MVP, MR. What happens on dynamic auscultation?
HCM MR with amyl nitrate, since there is increase in the obstruction with the fall in with the reflex tachycardia, there is increase in the obstruction.
So murmur increases in
Murmur increases in HCM.
of LVOT or MR?
Of LVOT.
So LVOT obstruction. So what happens to MR?
MR decreases.
No, so if the blood is not going here, where will it go?
It will go back. Yeah, MR increase. Yeah.
So if there is obstruction,
Yes.
more LV, smaller LV cavity, less amount of blood, but more obstruction, MR has to increase.
MR will increase. Okay.
It's correlated, right? That's how
Yes.
it goes.
Yes.
This increases, this increases, this increases, this decreases.
Yes.
Right. So those are the couple of questions that otherwise dynamic auscultation everybody knows. What are the other what is Muller's maneuver? How do you induce Valsalva bedside? What are the four phases of Valsalva? What are the difference between the four phases of Valsalva? What is Valsalva response? What is the square root response? What is which conditions you get it? I think those are the other questions. Are you aware of them, or shall
Yes.
I, for the sake of completion, let's do them quickly as well? We still have some time. So tell me, what is Valsalva ratio? What is Valsalva maneuver? How is it induced? And what is square root response?
So Valsalva is a forced expiration against closed glottis. It is
How do you do
patient
it?
has
Ask
been
the
asked
patient to
to
do it.
patient is asked to blow the sphygmomanometer for to maintain a 40 mm Hg pressure for 15 seconds. So
So
there's
is
a
it
initial
only
early.
Sphygmoman, or I can use Aneroid also? So Sphygmo is no more available actually. If you ask the patient to blow and he does Muller's instead of Valsalva, he'll suck in the mercury. So nobody allows you. That's not very safe. You can use it in aneroid meter as well. Either of the two is fine. Blow at 40 and then
Kept at 15 seconds at least.
right, hold it. So if he doesn't, he doesn't have, what else you can do? Other thing that the patient can be asked to do. Straining at a constipated stool.
Constipation of
Straining at a constipated
straining at
stool.
constipation stool.
Or third thing that you can ask, hand on abdomen and ask and hand on the mouth and ask the patient to blow so that he lifts the hand on the abdomen. So these three methods you can induce a Valsalva. Muller's?
It's opposite to the Valsalva. It's a forced inspiration against closed glottis.
How will you do that?
In both the limbs, we inflate the systolic BP to above 20 mmHg systolic.
No. How would you ask the patient to do Muller's?
Pinch both nose and mouth and then inspire. Try to
ask the patient to breathe in.
breathe in.
Okay. Right. And then what are the four phases of Valsalva?
First is the initiation phase when there is increase in the endothoracic pressure because the glottis is closed and there's a dead space which is built up in. So there's increase in the endothoracic pressure which augments the BP. The heart rate remains more or less same. Then there is a second continued strain phase which causes decrease in
So when you
the.
say changes on Valsalva, which phase are you dealing with?
I've been dealing with a strain phase of the Valsalva in the case of dynamic oscillation. Phase
2
two
and
of
3.
two,
So changes in phase 1 and
phase
4 are same, 2 and 3 are
2 and
same.
3.
When we describe Valsalva, the changes are of 2 and 3. So what are the changes in blood pressure and heart rate on phase 2 and 3?
The blood pressure decreases in phase 2 and the respiratory, the heart rate increases in the phase 2. Since there is a decrease in the cardiac output, there is a decrease in the stroke volume, the BP decreases, the mean arterial pressure decreases, which causes reflex tachycardia in phase 2.
So phase 1, you have what? What happens to pulse and BP? Phase 2, what happens to pulse and BP? Phase 3, what
Phase
happens to
1,
pulse and
there is increase in the blood pressure.
Okay.
With normal, with say the heart rate is stable. It is
No,
initiation. Heart rate
no,
decreases.
it's a,
Heart rate decreases since there is CNS activation and vagal
correct,
stimulation, so heart rate decreases. And second phase, there is decrease in the BP and increase in the heart rate.
correct.
With the release phase, there is it's the initiation phase, which causes decrease in the but there is the pooled periphery blood returns to the heart back, but since but the BP still decreases and there is a reflex tachycardia. In phase 4, there is increase in the cardiac output since there is increased return from the periphery and there is BP overshoot and also a decrease in the pulse rate.
Overshoot response. So what is square root response?
Square root response is in cases of constrictive pericarditis and cardiac tamponade, there is increase in the venous pressure,
Tell me more causes.
congestive heart failure,
Okay. One more. Two more, actually. And cardiac tamponade and constrictive, both or only one?
constrictive pericarditis,
Not tamponade, right?
I guess. Oops.
Yeah. So ASD and
ASD,
mitral stenosis
mitral
and
stenosis,
mitral stenosis.
mitral
So
stenosis.
somebody who's doing well in mitral stenosis may be asked what is the change, what are the changes that you'll get on Valsalva in a patient of MS. Overshoot will be blunted. Can you
Blunted.
explain in all of them why? All have
There is
different mechanisms.
yeah.
If you know these, you know dynamic auscultations. Why the mechanisms are different? They don't get overshoot response. That is what is called a square root response, which means post release Valsalva, as Kirti was
Overshoot
mentioning, what happens to pulse and BP?
overshoot is not there.
So blood pressure will shoot up and heart rate ka kya hoga?
Decrease.
Right. But
In
that
phase
does
4, it
not
will
happen.
decrease.
That will
It has
not
not
happen
happened.
in constriction, congestive heart failure, mitral stenosis, ASD. Those are the 4 causes.
ASD.
Sorry?
Yes, sir.
Yeah.
Yes.
So tell me why. All of them have different mechanism why it doesn't happen.
In case of there is in case of MS, there is increased pulmonary capillary wedge pressure, increase venous, increase
No. It's a fixed cardiac output. MS,
fixed
it's the
cardiac
orifice is same.
fixed.
Whatever venous return comes, doesn't come, this is the amount of blood that will pass through it. Fixed orifice does not allow increase or decrease venous return to allow more blood, less blood, anything. Fixed orifice does not. So like in aortic stenosis, your fixed output, that's why you get syncope. Equivalent of that in MS is absence of Valsalva's overshoot response. Are you getting it? The simile of hemodynamics. Okay. What about ASD?
Since there is there's no phasic variation with the inspiration. This same amount of
No,
blood
because whatever more blood will come will be balanced through the interatrial
it
defect.
will bypass from the ASD.
Yeah,
Yes.
so more venous return comes, it balances the shunt. So there is no effect of overshoot response. Again, if more blood is coming, it will shunt more. If less blood is coming, it will shunt less. The shunt is balancing out what will go through the mitral orifice into the forward cardiac output, so blood pressure will not shoot. What about constriction?
There is increase in the pressure in all. There is increased venous pressure in all chambers. There's increased pressure in all chambers since
Ventricular interdependence. Kirti, one word should come is ventricular interdependence. So more
exaggerated
blood
ventricular
comes, it shifts on this side, less blood
shift to
comes,
the
it
other
shifts.
side.
Right.
Yes,
What about congestive heart failure?
there is increase in the venous. There is increase in the pressures
More blood is
already. So
coming?
it's second.
No, because heart is already operating at the peak of the Frank-Starling
Peak of the-
curve. There is
Yes.
nothing more. Not it's a tired horse being flogged at its peak. Flog him more, he'll not run more. The heart is already operating at the peak of the Frank-Starling curve. More blood comes doesn't mean that it will contract more forcefully. The cardiac output increases, blood pressure shoots because more blood into the LV forces more power in the muscle and the sarcomere interaction, causes more force with which the LV is emptying. But more blood doesn't mean that in a patient with. So all four have different mechanisms why overshoot does not happen. This is the credit question that you may be asked when you're discussing a case of hypertrophic obstructive cardiomyopathy. These questions are not given in all the books or wherever you read or other channels. So I thought we should bring in something that's not covered in the videos. People should come and learn things that are not available on easily on other places to learn. So these are the questions that I thought I'll ask you. Okay, go ahead.
Other system examination is there's no abnormal in that. Provisional diagnosis. Severe dynamic left ventricular outflow obstruction at subvalvular level due to hypertrophic cardiomyopathy with mitral regurgitation in NYHA functional class 2. In sinus rhythm with normal LV systolic function, no pulmonary artery hypertension, and possibility of sustained tachycardia.
So you also need to define whether you're dealing. So a couple of things. One, what is missing? So what are the causes of different causes of subvalvular LVOT obstruction? What are the causes? Etiologies. Can you categorize? HCM is the only cause, or there is some? There
Subvalvular
can be
AS,
something.
subvalvular aortic,
which can again be of
subaortic
three types.
membrane.
So membrane is the
hourglass
third cause. So
appearance.
three causes: dynamic, which is HCM, then
Subaortic,
membrane
subaortic aortic source.
and subaortic.
Membrane,
Subaortic also three types. What are they? Three
hourglass
types of
appear,
subaortic: hourglass, discrete, and
discrete and
diffuse.
uh,
Correct. So
diffuse.
right. So those are the three types. So if the examiner is as well read as you, he will grill on you differentials of this. So why this is not subaortic membrane?
Since
I said this is
there is
membrane.
there is dynamic
Very good. So dynamic separates out the rest of them. Just the dynamic demonstration rules out the rest of the things. Again,
yes.
Why not a membrane? What else would tell you that this is probably membrane? Let me put it that way.
There will be
If membrane is present, something else will also be present. One more murmur will be present. Which murmur? AR. Most often, yeah, because the membranes are attached to the aortic leaflets. They will not allow it to close completely. If you can hear an AR, you rule out probably an HCM, HOC,
yes.
right?
Yes, sir.
Again, what about A2? What about A2?
A2 will be delayed in sorry,
Normal
with
in HCM.
Normal in HCM, it will be increased in A2 will be delayed with the subaortic membrane with the AR.
No. Either that it is increased. Everything is not related to what I'm telling. It will be loud in.
It will be loud in subaortic stenosis and subaortic membrane.
Which valvular? Bicuspid. Bicuspid aortic, that's where A2 is loud. Or dilated aorta, where the vascular A2 is coming, not the valvular A2. Right? Then hourglass, diffuse, etc. will present in a very different way. Again, you need to quantify MR. You need to tell whether there is family history or not, whether you think this is a genetic phenotype or phenotype and genotype. That also needs to be mentioned. So you say this is a phenotype of hypertrophic obstructive cardiomyopathy. Genotype needs to be evaluated. Genotype is not known, or genotype has a family history of sudden cardiac death, something like that. Okay. So this looks pretty good. Majan sir, anything else?
No questions from my side. You have covered.
Right.
You have covered everything.
Sir.
So, what is the
Okay.
difference between hypertensive hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy? And what is
Uh,
the difference between athlete's heart and hypertrophic cardiomyopathy?
Very important question.
Sir, in cases of athlete's heart, there will be the most important is LV cavity is LV cavity and systolic and diastolic dimension are more in athlete's heart. There will be no LG on CMR. There will be with detraining in 8 to 12 LVH. Also, there is the diastolic dysfunction will not be there in athlete's heart. The E dash and E dash and velocity will be more than 7. And diastolic dysfunction will be present in HCM. There will be symmetrical hypertrophy in
Age.
heart. Age. It will be young patients in athletes heart. Yeah.
So that's how it starts. Whenever you're asked any differential, start from, if the name can tell you, if name is from K, he's likely to be, so start from there. Otherwise, you'll go haphazard. You'll go E coca, E prime, then you'll think of LVH. So if you start name, no difference. Age, gender, history, athletic history. So history, whether patient has a history of
Okay.
athleticism, that itself will tell you, right? So that's how
Yes.
very important. Sir was asking the other thing: hypertensive heart disease, hypertrophic cardiomyopathy, hypertrophic obstructive cardio. What is the difference between all of them?
So hypertensive heart disease, there will be a prolonged history of hypertension with normal there will
So
be no
somebody
dynamic.
has IVS, PW, echo done. You're doing an echo, Kirti. You must be doing a lot of them. And you find an IVS, PW of 13.5 by 13.5. Is he HCM?
If he has no family history, though, then he's not at same.
Okay, he does not have family history. He says, I'm taking telmisartan 20 for last 20 days.
So it might be hypertensive heart
Okay,
disease.
what is the cutoff of defining an HCM? Old definition,
15
new
mm,
definition.
15
That is
mm
old
Hg,
definition.
15
That is old
for
definition. That is old definition. That's why I was asking you. The new cutoff is
IVS
not
PW
15 or
ratio of more
16.
than 1.3.
No, that is ASH. That is definition of asymmetric septal hypertrophy. Absolute value is more 13.5, not 15.
13.5.
Yeah, so that's why I was asking you this value of 13.5. Then how do you differentiate? Again, Majan sir's question.
There will be
13.5
no
is hypertensive or is it HCM?
sir, the other symptoms of pre-palpitation
It
and
may be early, no?
pre-syncope
Patient
might
can
not
have
be there.
a early presentation. 22-year-old chap
Early
walks
present.
into your chamber. Okay, can you again go
Okay.
back and tell me causes of MR in a patient of HCM? Kirti, I think by mistake has left. She can join back. So in the meanwhile, so MR is one of the way of differentiating, because usually the mechanism of MR is anomalous insertion of the anterior mitral leaflet into the differential papillary muscles. Also the anomalous abnormal caudal insertion in these patients, presence of MR which is more than significant, asymmetric hypertrophy. Again, there are subtypes, which is the apical HCM type, which is benign in nature compared to obstructive HCMs. Also, patients in Asian, Japan, usually have the apical variant. These are more benign and they don't have more likelihood of sudden cardiac death. So, uh, 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 if yeah, Kirti is there. Kirti?
Sorry, sir. Sorry, sir. There's a
No,
glitch.
that's fine. Yeah, no issues. So we were discussing the Asian and the Japanese having more likelihood of the apical
Cycle
variants of it.
HCM. Yes, sir.
Yeah. And then the variants of it, the ASH definition of 1.3 ratio, then M mode showing. What does M mode show?
Anterior mitral leaflet contact with the interventricular septum.
Contact and
Systolic
more than that.
drag effect.
SAM,
SAM.
systolic anterior motion of which? Anterior leaflet or
Anterior.
posterior?
Actually, both of them. There is
Both of them.
but more commonly of
But usually the anterior is good enough, and that's how you have gradings. Only anterior, only
anterior.
posterior, how much it is moving, SAMCA grades. Right. So
Yeah.
what do you want to do for this patient now? What is the
Uh,
next approach?
Sir, my patient.
Do you have any other X-ray ECG slides?
Yes,
This
sir.
patient? Yeah. So do you
This is
think this is
a
classical of
12-year
HCM or it's not?
It's not classical of HCM since
Correct.
it is
What do you
no T
anticipate?
inversion. Pathological Q wave, T wave inversion, left atrial
Q
enlargement,
waves, one more common is T inversion
T
rather than
inversion,
Q wave.
symmetrical T. Yes, sir.
Q or may not be there, right? But this is
Yes.
not classical, right?
Yes, sir.
Okay. So coming back to last time's question, I had asked in last series, how do you estimate severity of aortic stenosis based on ECG? My question was, is there any formula? A lot of students have texted me personally, sir, what is the formula? It's called Seigel-Roberts equation. It's basically sum of all positive and
Of
negative
all
waves in the
precordial.
ECG
Yes.
minus subtract the systolic blood pressure is the gradient. So Seigel-Roberts equation gives you severity of AS. Because a lot of students personally text me, I asked that question and did not answer it. So I thought now that you've shown an ECG, I'll recollect that. And the series also continues in the continuity for the first lecture and the second. Okay, the X-ray. So there is nothing significant in
Yeah, that's
this
significant in the
that is
X-ray.
typical of. Again, what do you expect in chest X-ray in a patient of HCM?
Sir, nothing significant.
Nothing much. It'll probably
Nothing.
be a normal, but you can calculate LV mass. Can you
LV
calculate
mass.
LV mass from chest X-ray?
So with X-ray, I'm not sure.
Yes, there are formula which are of the cubes of the length, breadth, and height. Height is measured again by the base of the eye from the right CP angle to the pulmonary bay, and then you count the cross section and calculate the volume, and then based on that. But again, there are a lot of AI tools coming in now. That's where your Viva can come in. Can you estimate wedge pressure? Can you estimate X-ray wise diameters? So echo, go ahead.
Yes. This is a Plaques view, modified Plaques view showing the systolic anterior motion and the AML contact with the interventricular septum.
SAM is demonstrated in which view ideally?
Apical 3 chamber, the Plaques view only.
But M mode, of course.
M
That's
mode.
what I wanted.
Yes, M mode.
Right.
It's
Okay.
M mode across the. This is a short axis view at apex.
Okay.
At mid papillary level.
Mhm.
100 base. Apical 4-chamber view showing hypertrophy.
Why ECG gating is important in this patient?
If at all we if at all there is VPC, then we can demonstrate.
Very good, very good. So that's why in a patient of HCM, you should do a ECG gating. Number one. Number two, what about SAM being false? What are the other causes of SAM apart from HCM?
Sir, post procedure with the dehydration, there can be.
Even without any patient with dehydration can have severe dehydration. Any
Yes.
other condition where there may be SAM or paradoxical septal motion? Patients with ASD, patients with severe dehydration, patients with pericardiectomy, constriction. These patients can also present both with paradoxical septal motion as well as SAM. Next slide. Go ahead.
This is the continuous wave Doppler put across the apical 3-chamber view. Same.
Okay.
Shows there's a turbulence noted across the left ventricular outflow tract. It shows the dagger shape of 38 at rest.
Really think
With
it's only
Valsalva, it is
38?
so
You did Valsalva, okay.
we did Valsalva, it is 58 with Valsalva.
Okay. So what?
Can standing may we can do echo.
So after Valsalva, you
After
mean no, Valsalva will cause what? Worsening of gradient or increase in gradient?
increase in gradient.
So you do
In the strain,
Valsalva. Which phase? Release phase or strain
strain
phase?
phase. In the strain phase. In the strain phase,
Right.
there is an increase in the
You can ask simply the patient to stand and put the
stand
probe.
in.
That's all.
Yes.
Yeah, standing, look at the gradient on standing. It can change.
Yes.
Simply standing from supine, you've kept the patient supine, ask the patient to stand and look at the gradient from the LV.
Yes.
Right,
Yes.
55. Okay, next. So I think Dr. Rakesh Yadav had already covered a lot of stuff on sudden death, predictors, gradients. I'm not asking you those questions.
Yes.
Yeah.
This is a
Okay.
diastolic dysfunction. The pulse wave Doppler pulse wave is kept on the mitral valve, and which shows EA
Right.
ratio more than 0.9 and decreased E dash Doppler tissue Doppler velocity.
Okay.
So this is MRI actually.
Good.
Delayed phase. Had the patient has significant late gadolinium enhancement at the short axis view.
What percentage is defined as a cutoff by American
More than
Synchronized?
15% of LG is defined as a predictor of sudden cardiac,
And
predictor of
some say about 10 also.
10.
So 15, of course. The
Yes.
sensitivity specificity is much higher for 15. For 10 also you can think of. Yeah, there is LG. Right. So what is your next plan? Now we've done this. He's got an MR. He's got a gradient. So what medications you'll start with, or you want to put an ICD
So we
directly?
can start beta blocker. We can escalate the dose of beta blocker,
So I
and we
give
can
you
add
three
non
choices of beta blockers. I'll give you three choices of beta blocker: atenolol, metoprolol, and propranolol. Which one do you want to choose?
propranolol, beta metoprolol.
Why?
Sir,
Again, applying your pathophysiological concepts. That's all. Propranolol is less selective. So what is the unopposed?
non-selective
What will that cause?
alpha.
What will that
That
happen?
can cause
Vasoconstriction, more
vasoconstriction,
LV cavity,
more LV
less
cavity.
relief. So
Yes.
theoretically, propranolol may be a choice, but then either can be used. So, I mean, this is how you assess. I mean, I know there is no difference between the data sets of either of the beta blockers, but a good student would answer, sir, theoretically speaking, propranolol is non-selective, so alpha is unopposed. So probably some amount of peripheral vasoconstriction may be helpful in relieving his symptoms of angina by relieving some amount of vasoconstriction. So just applying the concept, metoprolol, right? What dose?
So 50 to start with
100 BD, 200
100 BD.
milligram is the dose, right? That's what you use. Will you combine, suppose his heart rate is still 70 after 100 BD? What next?
Non-dihydropyridine calcium channel
So you will
blocker.
add calcium channel blocker to it?
Yes, sir. Can be combined. Verapamil or
No, no. Remember, that's one combination that you don't give. What is the next drug that you gave?
So
Disopyramide. So beta blocker plus disopyramide or calcium channel blocker with disopyramide.
Yes.
If you cannot go down on rate, people do combine calcium channel blocker with beta blocker, but that combination is the last combo to be used. It's class 2B. Combine disopyramide with either calcium channel blocker or beta blocker with calcium channel disopyramide. Now it's not available. What's the newer drug? If it's not available, that is. Suppose you have given disopyramide. What side effect you are worried about?
Sir, it increases.
Mavacamtan. You know, everybody knows mavacamtan. So, what disopyramide? Let's go back to the old drug available in India. Is it available?
It can. Yes, sir. It is available.
Yes, Norpace. It's easily available.
Yes,
it's available. So tell me, what are the instructions you'll give to this 60-year-old gentleman walking into a chamber? He's an HCM. He's lived for 20 years with it. No otherwise syncope, doing well. You now want to start him Norpace, disopyramide. What are the things that you'll tell him?
So first I'll start disopyramide with
or
the.
What are the things you'll check him for?
BPH first to have to be ruled out since there is a anticholinergic
Very
effects
good.
of
Very good. So prostatism, he may end up with then you'll have to
tension of
write a
urine.
fitness for his surgery for prostate TURP. So be cautious about that he doesn't have an obstructive prostatic hypertrophy. Then
Also, it
one
has to
more
be
thing.
started with AV nodal blocking agent since it
Arey,
increases
glaucoma.
glaucoma it can cause. Yes.
Second thing. So again, and what will you tell your patient? What do you tell your patient? You'll get some dryness of mouth.
Dryness of mouth.
Don't be worried, right? That's a common side effect. You may get some dryness of mouth, dryness of eyes. If you have any symptoms, eye pain, loss of vision, prostatism, come back and tell me. That's it. You were saying something? You think you were answering
It should be combined with alpha node, AV node blocking drugs since it increases AV conduction.
That you are already giving beta blocker plus this or right. Which so
it increases QPC, though it can cause T and R on T on TDP. There's a
yes, it can cause torset. So that's why, right? That you have to be cautious with that, right? Okay. So those are the drugs now. Now I want to. This patient needs a surgery. What's the next plan? or what would you suggest between the two surgeries? He says, you suppose this is 55. Mostly you'll give him good beta blocker, disopyramide. LG is high. Would you give an ICD?
Uh,
Estimate his risk. Do a
have
halter.
hold on.
Do a treadmill. Will you do a treadmill?
Sir, can uh, treadmill can be done to risk stratify to see the abnormal
Absolutely.
BP response
And
and
exercise induced
exercise
arrhythmias.
induced
Both.
arrhythmia. Yes, sir.
Both of them. So Holter, stress test, cardiac MR, you're done with most of the workup. Echo, you've looked. Need not cath if the angina is not very bad. Do a CT if required. Cardiac MR has shown that the pattern is not of ischemic type. So you know pretty much not an obstructive CAT. Now that you've risk stratified, let's assume that he needs an ICD. Before that or after that, will you do the surgery? Supposing that he has a still good amount of symptomatic residual gradient. Before or after? Suppose this patient needs both ICD and surgery. What goes in first?
So septal reduction therapy.
First surgery or first ICD? That's my question. Septal
First,
reduction or ICD first? Which will you do first?
ICD first.
You are an interventional cardiologist. Your surgeon says, I'll do myectomy. You say, no, 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 I don't know. I want to put an ICD. Who's right?
I'm not sure about it. Maybe ICD first.
No, why? No, you will not. That's the whole point. If you put an ICD and the surgeon doesn't get the patient out of table, he's ended with a VSR. What is your IC going to do? It's
Yes,
going
sir.
to fire all throughout the OT. And
Yes.
worse even than that, he does a sternotomy, pulls out the sternum, and your lead is dislodged now.
Yes, sir.
So
First,
first, if
myectomy.
you have a reduction to be done, reduce first, then put an ICD. Okay.
Yes.
Then between the reductions, between the two reductions, which of the two will you choose for him?
In
Alcohol
case,
septal ablation or myectomy?
sir, in case of good volume set of centers, I'll prefer myectomy since the mortality is less than 1% and there is immediate reduction in the obstruction and the effect is long term. But then if the
So young patients, old patients.
young patient, I'll prefer myectomy since it
Very
will
good. This is important. Young patients, myectomy. Old patients, you
old
can go
patient.
for alcohol septal reduction.
Yes, sir.
RBBB, LBBB, the other important
Other
thing.
important.
This patient did not have. So suppose this patient has
LBB to
RBBB.
RBB to I'll prefer then I'll prefer myectomy. Sorry.
When you do MI, when you get anterior wall MI, what does happen? RBBB anterior wall hota hai ya LBBB
RBB
anterior? RBB
RBB.
anterior wall. Now
Anterior.
patient already has RBB. You do myectomy. What will happen?
If RBB, then I'll do alcohol septal ablation.
Yes. So if RBB, you do alcohol septal. Because in an RBB, if you do myectomy, you'll create left bundle branch block. He already has right bundle gone. He'll end up with a permanent pacemaker.
Yes, sir.
So then ICD will work like a pacemaker. Then you'll have to put dual chamber ICD, which is working like a pacemaker.
Yes, sir.
Right. So remember this. If you have RBB, do alcohol septal ablation. If you have LBB, do myectomy. Because myectomy, complication of myectomy is LBBB.
LBB, yes.
And the only complication which is more in myectomy compared to alcohol septal ablation is bundle branch and conduction abnormality.
Yes.
So myectomy, you're risking for more CHPs and perioperative ventricular septal perforations. Barring those two, everything is bad on this side. Alcohol septal ablation, there is recurrence, residual gradient, more arrhythmia, more risk, more shocks, recurrence, LV dysfunction, scar, operative stroke. Everything is more. Here, the two things that are more are these two. Okay. Dr. Majan, sir, any other question or any other input?
Now everything is covered according to me.
So I think your resident is very well trained, Dr. Majan. Kirti has prepared very well. I think she allowed us to actually ask her questions beyond what is normally taught, because otherwise, if she was not answering those questions, we would be asking the same questions. And I think Dr. Professor Rakesh Yadav's presentation also helped and saved a lot of time for us to actually ask a lot of IVA on sudden death. He actually covered it beautifully. And it was a wonderful session. Dr. Anil, you want to say something? I don't know why Dr. Anil is not able to unmute. Yeah, you can, sir.
Yeah. So I will thank you as well as Dr. Rakesh Yadav and Dr. Mahajan and Dr. Kirti. She presented case very confidently and very nicely. So I'm sure that she has learned a lot today, how to appear in the exam, which is our primary goal, to prepare students for exam. So we will continue to do so. Thank you, everyone. Good night.
Thank you. So, Dr. Mahajan, any closing words? Then we can end the session. I think Dr. Rakesh Yadav had to go for an important another meeting, so he's left. Mahajan, sir? I think sir is in a poor network zone. All right then. So thank you very much.
Good night.
Can
Thank
we
you.
have the slide for next presentation? RX events. Can we have
Yes,
the
sir.
slide of next session coming up? The last slide of our presentation. So we had wonderful 750 plus students participating last session, and I'm sure these were equally good numbers this time. Ankit, if you can show if you can show the session when the next one is due.
Yes, sir. Yes.
Yeah, would it be available on YouTube or something like that?
Yes. So both
Please,
previous session and this session will be made available on the CardioCon YouTube channel after the end. Right now it is live on RX TV, and then they will be uploading it, the recorded version, on the YouTube channel as well. So, Dr. Ankit, Ankit, can we? Yeah. So this is how the cardio class is. And the next time we are going to have Dr. Mohit Goyal, again from KEM. He'll be presenting case of acyanotic heart disease, and Professor Dr. Sandeep Bansal, who's the former HOD and Professor Department of Cardiology at Safdarjung Hospital, New Delhi, will be our expert. He will be taking us through approach to a case of shunt physiology. This is scheduled on 10th of December. Again, a blockbuster Thursday, not Friday, 8 p.m. I look forward to have you all. Stay connected. I thank ISCM. I thank Dr. Ajay Mahajan for being there all throughout and guiding us, and ISCM and its faculty for giving this opportunity to interact all across India. Thank you to Supto on behalf of Astra, and thank you RX Events for helping us host the event. Thank you. Good night.
good
Take
night.
care. Bye-bye.
Thank you. Thank you, everyone.